Hello, welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. I'm Rich Duzak from Emory University, and this module is the first part of the series on compliance entitled The Problematic Order. This module is targeted to Level 5 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to understand rules imposed by Medicare and a variety of private payers on the ordering of diagnostic imaging examinations, to outline exceptions to those rules that permit radiologists to provide the most timely and appropriate imaging services to their patients, and to implement workflow redesigns to improve value to patients and referring physicians alike, all the while ensuring regulatory compliance. Here are some additional resources listed alphabetically by author and chronologically for those who would like to learn more about the topics in this module. Dr. Brown didn't order the right study. What should I do? It's a question you've probably been asked in one form or another many times so far in your career, and one that you will continue to be asked regularly until the day you retire. The perhaps naive answer, as an idealistic physician of course, is to just fix the order and provide the patient the service that she needs. But we know from earlier modules that if not done in compliance with all payer rules, that could result in an unnecessarily hefty bill to your patient. And as we'll talk about in this and the ensuing couple modules, potentially some legal trouble for you and your practice as well. In this module, we will talk about some common ordering problems that you may run into in your practice and separate those ad hoc, individual order issues with broader, systematic issues that may plague your practice and the practice of radiology more broadly. And finally, I will spend a few minutes challenging you to think outside of the box a bit, to get out of the transactional way in which most of us practice radiology, and think about ways to redesign your imaging workflow to provide better value to your patients, your health systems, and to your entire practice. All along the lines of the imaging value chain that we've talked about many times so far throughout Replete. Problematic orders come in a number of different types. There are some that are, quote, incorrect. Some of these are obviously and clearly erroneous. And for others, the order may not necessarily be wrong per se, as much as we as radiologists may differ with our clinical colleagues in what we consider to be ideal. Problematic orders also include those for services which we now know that payers will not cover, whether that's because the available clinical history is clearly incorrect or insufficient, whether the payer doesn't think the examination is correct, but everyone else does, or whether the payer considers the service investigational and therefore never covered under any circumstances. Back in a module in Level 3, I introduced you to Medicare's ordering physician rules. These were designed by Medicare, presumably to prevent radiologists from churning unnecessary imaging. Originally, Medicare took the position that radiologists are required to perform the exact services ordered by referring physicians, regardless of whether they best serve the needs of their patients. But after a lot of dialogue with the American College of Radiology, Medicare backed off on that a little bit, but not as much as most of us would have liked, to give radiologists a bit of discretion to best serve our patients' needs. That so-called ordering physician rule was the focus of Transmittal 1725 back in 2001. As you may recall, that rule outlined 3 specific blanket exceptions to that original no modification under any circumstances position. The test design exception allows us as radiologists to protocol a generic order as we see fit. So, if you get an order for CT of the abdomen and pelvis with no mention of contrast, and it's for a Medicare beneficiary, you can protocol contrast as you see fit. But if the order is specifically for a non-contrast examination and you think contrast is necessary, then this rule does not apply. The clear exception is another one you need to know. If the order is clearly wrong, not to you as a board-certified subspecialty radiologist, but to a layperson such as your front desk clerk, then you can go ahead and fix it as you see fit. Many of these fall into right versus left side transcription errors. And finally, you should know about the patient condition exception. Say a patient shows up for a DEXA scan, but develops chest pain in your waiting room. You're given permission here to do what is clearly the right thing. Get that patient evaluated in the emergency department or wherever necessary, rather than proceeding with a test that could delay the treatment of something that could be more life-threatening. In addition, Medicare allows for two very narrow exceptions in certain subspecialty care circumstances. First, the breast imaging exception permits a radiologist to order a diagnostic mammogram based on the findings of a screening mammogram, even though the radiologist does not treat the Medicare beneficiary. And a radiologist is then granted authority to move ahead with a diagnostic mammogram when reasonable and necessary. But of note, no such exception exists for ultrasound or MRI. For those different modalities, you will need an order from the patient's treating physician to proceed. Most of us know that interventional radiology is increasingly practiced under a clinical care model. Fortunately, Medicare recognized that even many years ago when they stated that a radiologist performing a therapeutic interventional procedure is considered a treating physician. Of note, though, that exception only applies when the IR is serving as the treating physician. That is, not when he or she is performing services in the capacity of a diagnostic radiologist, as some may do either between procedures or on non-procedural days. Now, those are all Medicare rules. Each private payer has its own set of rules. But fortunately or unfortunately, almost all private payers contract with a very small number of radiology benefits management companies. And most of these require some form of pre-authorization. That is, for all elective advanced imaging, they typically require pre-authorization, sometimes known as pre-certification. What does that mean? If pre-authorization is not obtained in advance of the service, payment will be denied. Importantly, though, and we'll talk about this in some other modules, pre-authorization does not guarantee payment. For some radiology benefits management companies, any modification of an order at all will result in a denial. Meaning, even if you determine that the pre-authorized contrast is not necessary to answer a particular question, and you go ahead and perform a less costly non-contrast study instead of the approved contrast-enhanced examination, they'll still deny payment. That's something I call deauthorization, and something we'll talk about in just a few minutes. In contrast, those radiology benefits management companies that do business in a more ethical manner will pre-authorize a family of codes, which basically refers to the three flavors of CT or MRI that we talked about many modules back when we focused on CPT coding. That is, the family pre-authorized would be non-contrast, contrast, or a pre- and post-contrast study. The radiology practice in those settings can take their pick depending upon the details that they learn when they review the patient's chart and talk with her when she arrives in their department. Let's pivot now to some specific scenarios. And for each of these, we'll talk about both problems and potential solutions. The history is no good is one variation of this theme. In this case, the history can be incorrect or completely inapplicable, as in the setting of, say, chest pain, as provided for a history for an ankle radiograph, or trauma when the patient specifically denies trauma. How about rule out fracture or just generic pain? Sometimes these can be correct, but incomplete. You know from modules early along in level 1 of Replete that rule out is never an ICD-10 codable diagnosis. And some histories like pain are pretty non-specific when coders often need details about location, chronicity, and etiology to code to the highest level of specificity with regard to signs, symptoms, or specific diagnoses. The answer here is pretty simple. Get better information. Sometimes that means getting it from the referring physician or her office, but don't forget that you can get information from patients as well. Some compliance officers have incorrectly told radiologists that clinical history must be included on the order for the test. But Medicare disagrees with that. In fact, the agency has provided specific direction on this issue in its claims processing manual. What did they say? When the interpreting physician, that's you or me as the radiologist, does not have diagnostic information as to the reason for the test, it is appropriate to obtain the information directly from the patient or the patient's medical record if it is available. So, talk to your patients. It's an opportunity to not only help yourself get paid, but to remind them that your team cares about them as individuals. You may recall as well that many modules back I told you about our experience at Emory, in which we piloted a history augmentation project with our sonographers for the so-called rule-out DVT venous duplex examinations. We have since rolled that out all across our enterprise, and we encourage our technologists to capture legitimate history from patients and document it in our radiology information system. What do we ask them to capture? What, when, and where, whenever possible. It helps us as radiologists provide more meaningful interpretations to have that history, but it also allows us as an enterprise to do a better job capturing legitimate revenue. In this case, sometimes as much as 30%. How about this problem? The order is wrong. Wrong is a relative statement, but CMS has said that if it's clearly wrong to a layperson, then they would indeed consider that wrong and allow you as the radiologist to change the order without any additional permissions. Here are a couple examples: a left ankle x-ray for a clearly injured right ankle, or an abdominal pelvic CT scan for a history of headache. We're not talking in these situations about nuances of ACR appropriateness score differences. These are cases, I think, where your registration clerk would be saying, hey, that doesn't sound quite right. The solution, again, get more information. Sometimes that means getting a new order, particularly in the setting of a commercially insured patient who has already gone through pre-authorization. Remember, changing an order just a little bit may mean that the private insurance company will completely deny payment. But don't forget to check on the patient's insurance status. If he or she is a Medicare fee-for-service beneficiary, you can just fix a lot of these yourself without bothering your referring physicians by exercising the clear error provision in Medicare's ordering physician rule if it really applies. A twist on the wrong order is, I don't agree with this order, where the so-called error may not be so obvious to a layperson, and maybe not even to a more sophisticated individual. That could be you as a radiologist, or it could be a payer that you know has a policy that won't pay for X or Y or Z. These situations typically require conversations with the referring physician or sometimes with the insurance company. The latter, of course, can be a painful process. But getting it right rather than just doing it is important. Don't forget the example from several modules back where the entire radiology practice almost got fired for regularly paying no attention to appropriateness. And by now, you should remember my conceptual equation of quality. If appropriateness is 0, so too is incremental quality. We are physicians, and as such, we all have an obligation to ensure that we deliver high-quality care. A related twist on the disagree with order scenario is this service isn't covered. In this case, it's the insurance company that's not agreeing with the ordering physician or with you. Sometimes their concerns are legitimate, such as for a study where the appropriateness criteria score is 1, or maybe not even on the appropriateness criteria list, and you can't get pre-authorization, because there's general agreement that the service isn't indicated. Say an abdominal CT scan for a headache without any further information. In this case, we're dealing with the CPT-ICD mismatch that we talked about many modules back. In other cases, the service isn't covered under any circumstances at all, regardless of the ICD diagnosis. In this case, we're typically dealing with a service deemed investigational or experimental by a payer, like CT colonography was in its earlier days. And you now know the story of how ongoing advocacy by the ACR and other professional societies has helped to change that. Any attempt at a solution with this set of problems as well is also going to require a conversation with the referring physician or the patient in order to get more information, or with one or both of them if they're insistent upon a service that a payer won't cover. Sometimes they will need to join you in pushing a payer for coverage, but this is often an uphill battle. That's where the ABN comes in, the Advanced Beneficiary Notice. An ABN is essentially informed consent that you give to patients, formally notifying them that if they proceed with a non-covered service, that they're going to be held responsible for the bill themselves. Medicare says you can't balance bill patients for non-covered services unless you have obtained an ABN. So an ABN is a notice that's given to a patient before a service that, based upon Medicare coverage rules, you as the provider have reason to believe is not covered, either because the indication is not covered or the service at the CPT level is not covered at all. So it behooves your practice to be aware of what is covered and what is not. Otherwise, you can't have these conversations up front. Sometimes patients are insistent upon receiving a service, but they change their minds once they realize that their insurance will not be paying. And as such, these conversations often get into many of the cost-related and shared decision-making ones that we discussed way back in modules in Level 2. So far, we've talked about problems with individual orders, but there are some systems problems with which many radiologists struggle. Some come from outside their institutions, and particularly from the dreaded RBMs. And for some rare radiologists, though, they come from inside their institutions, with administrators in their compliance offices who sometimes stand in the way of good care. Let's talk about each of these individually. You've heard me use the term deauthorization a few slides back. Rather than try to define it, let me share with you a real case. It's a patient with a questionable nodule on a chest x-ray who was referred for a CT scan of the chest. A contrast-enhanced examination, note it's contrast-enhanced examination, was pre-authorized by the insurance company. But after the patient offered the radiologist a history of a prior near-fatal anaphylactic reaction to contrast, the patient underwent a non-contrast study, which turned out to be diagnostic. But the payment was later denied on the basis of a non-approved study with a statement that the pre-authorization was specific for a contrast-enhanced examination. So, this radiologist did exactly the right thing and actually performed a totally adequate study that saved the payer money. That is, they didn't have to pay for contrast. But nonetheless, payment got denied because of what I consider a sneaky gotcha trick. There's at least one of these companies that still engages in this practice pretty frequently. And in these situations, there is no easy answer. I had a case not unlike this several years ago when I engaged the patient and gave him the direct phone number of the chief medical officer of the Radiology Benefits Management Company. Guess what? That study got approved on the spot by the CMO. It seems they really don't like defending these types of practices if they actually have to do it to patients themselves. Indeed, the squeaky wheel can get the grease. And if you're dealing with deauthorization tricks that impede you from delivering good care and good service, make sure you let the insurance company know that. They're paying these intermediary companies good money, and these third-party intermediaries do not reflect favorably upon their insurance company parents. And finally, each time one of these situations arises, it's a great chance to advocate for better utilization management solutions. And with that, I'm talking about utilizing computerized physician order entry with embedded decision support as a real-time approval process, something that we've already talked about in a good bit of detail in the last module. I'm also unfortunately aware of a few instances where hospital administrators, and specifically overzealous compliance officers, are the ones preventing radiology practices from providing good clinical care. Don't get me wrong, we're only talking about a few bad apples here. Compliance officers are individuals who are charged with overseeing the billing processes, audits, and education that's necessary to ensure the highest level of integrity and accuracy in billing. Unfortunately, the easiest response in the world for some uneducated compliance officers is simply to say no to everything. That is, you'll never submit an erroneous bill if you never submit a bill at all. But that's not a financially sustainable solution. Good compliance officers can be worth their weight in gold because when the regulatory seas get rough, good compliance officers help safely steer their organizations through those rules and appropriately propose ways to deliver good care rather than withhold it. Let me tell you about a story that Dr. Lenny Berlin and I published some years back about a compliance officer whose actions led to really bad care, a delay in the diagnosis of breast cancer. This is a story about a 58-year-old woman who presented with an order for a screening mammogram for a breast lump. Yes, an order for a screening mammogram. The practice did no additional imaging, didn't even ask about it. A breast cancer was allegedly missed and only diagnosed when locally advanced a year later. And as you can anticipate from the way I'm telling the story, a medical malpractice lawsuit ensued. During his deposition, the radiologist interpreting the screening mammogram was asked why he didn't convert the screening mammogram to a diagnostic mammogram. Here's what he said: "I'm not allowed to change an order. That would be fraud." In fact, he went on to say that he was told by his compliance officer that it would be fraud for him to even recommend a diagnostic mammogram in follow-up, something clearly contrary to all standards of care, and something not supported in any way by Medicare rules or policy. The compliance officer, of course, was then deposed and asked why she did this. And here's her response: "I basically want to put the fear of God into radiologists and everybody else who works here." With that now in the court records, the radiologists in the hospital were unable to find a single expert witness to aid in their defense. In fact, here's what one potential expert opined. In offering what amounts to a "my hands were tied by the government" defense, the defendant radiologist unfortunately fell prey to a draconian misinterpretation of Medicare rules by a hospital bureaucrat. Both parties settled out of court with the plaintiff for an undisclosed amount of money. Please don't let this happen to you. You may recall that the diagrammatic chain from order to dollar I shared with you in a number of modules back. Here's one variation of that, focusing on the steps relevant to this module between an order and an examination getting performed. What typically happens for commercially insured patients is this: the referring physician obtains a pre-authorization, and when the patient shows up for that study with a pre-authorization number in hand, the radiology practice protocols it, sometimes picking a study that's not exactly what got approved. The problem here is that pre-authorization often happens before there is any meaningful radiologist input into a case, and that's why it's sometimes just plain wrong. Let's tease apart this chain just a bit, though. Pre-authorization is not always required. You know that traditional Medicare fee-for-service does not require pre-authorization, but will soon require the use of a decision support tool. And even for commercially insured patients, pre-authorization isn't typically required for radiography, mammography, and ultrasound. So it behooves you to know a patient's insurance status at the time that studies get ordered. Because if you know up front that a patient doesn't have traditional Medicare and is presenting for advanced imaging, you'll have to make sure that your practice works with your referring physicians to get the pre-authorization step just right. What this means is that you need to implement processes, ideally at the time studies are ordered, to identify the patient's insurance status. Because if they have traditional Medicare, you can typically bypass the pre-authorization step entirely. But what if you know that the patient has commercial insurance and the order is for advanced imaging? Then you know there will be an RBM involved. In that situation, you'll want to work with your administrative team to see if you can identify upfront whether they approve families of codes or whether they play silly gotcha tricks. Either way, though, the best solution is to figure out a way to flip these two middle steps. Meaning, can you get the order, vet it, and protocol it, and only then work toward pre-authorization? These are solutions that we, like others, are working on in our practice. The best solution, of course, is to utilize real-time decision support and get this right in real time, just in time, when the clinical decision is being made. Ultimately, the goal is to get as much of this chain front-end loaded to the left at the time of the order or quickly thereafter. Now, this all applies just as well in a Medicare environment when you don't have to deal with pre-authorization. The best way to fix incorrect orders is to not have to fix them at all, meaning getting them right up front. Again, vetting an examination and protocoling it in real time or near real time. And again, that's where clinical decision support comes into play, something most of our practices will soon be implementing if we have not already. I realize that this is all easier said than done, but the goal here is to implement solutions like the ones I'm talking about that optimize the imaging value chain at every step along the way, cutting down on bureaucracy and making sure that the entire process is easier for your patients, your referring physicians, and you as well, all at the same time, all the while keeping you squeaky clean from a compliance perspective. Ultimately, that's the goal of Imaging 3.0, which is the American College of Radiology's framework for radiology's future. It's to make as many of these steps as seamless as possible. Again, it's easier said than done, but ultimately this should be our goal as we all strive to add value and deliver the best care possible and build in real time compliance protections all the while. In summary, then, as we serve our patients, radiologists must comply with the sometimes opaque and ambiguous rules that are imposed upon us by payers. The stakes for noncompliance can be very high. An understanding of those rules and regulations, interpreted in the context of high-quality patient care, and that's important, will help radiologists navigate this complex space. I would encourage you to not be afraid to respectfully push back against fictitious rules that may be imposed upon you by well-meaning but uninformed individuals that could impede your ability to deliver the best patient care. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Replete.